Welcome to the GMJ Podcast, the official podcast of the Georgian Medical Journal. In this series, we present structured discussions of peer-reviewed contributions published in GMJ, examining their implications for clinical practice, medical education, and health policy. This episode marks a special occasion. We are presenting the inaugural Health and Migration Knowledge Hub, a comprehensive open-access resource platform developed by the Georgian Medical Journal and the Public Health Institute of Georgia, dedicated to refugee and migrant health globally.
Right, and it's a really exciting launch.
It really is. Okay, so before we get into the weeds, I want you to just picture something for a second. Imagine you are a triage nurse in a really busy border clinic.
Okay.
And a patient arrives. They are severely dehydrated from, say, a climate-induced drought. They're pregnant. And on top of all of that, they're carrying the compounding, totally untreated trauma of a 3-month migration journey.
Yeah, a scenario that is unfortunately incredibly common right now.
Exactly. And you have maybe 10 minutes to assess them. What do you do? I mean, where do you even begin to unpack that?
It's overwhelming.
Right. And today, we are doing a deep dive into a platform that was literally built to answer exactly that question. We're exploring this newly launched Health and Migration Knowledge Hub to really understand how, the overwhelming volume of global health data can actually be weaponized in a good way to save lives on the front lines.
And it represents this profound shift in how we approach global health, really. Because for decades, migration health was treated as this niche subspecialty, something for humanitarian NGOs to worry about.
Like an afterthought almost.
Exactly. But if you look at the 2025 to 2026 mid-year trends from the UNHCR, the scale of global forced displacement, it's no longer an anomaly. It's the baseline.
The baseline, yeah. And the numbers are just staggering. We were talking about millions upon millions of people uprooted by conflict, economic collapse, climate shocks. And then you have the World Health Organization's landmark 2022 World Report on the health of refugees and migrants. And that made something brutally clear, which is that our traditional static health systems were just fundamentally not designed for a world in motion.
They weren't. And the central tension that gets highlighted in those reports, it's not a lack of data. I mean, the global health community has produced more epidemiological studies, more policy frameworks, and more clinical guidelines in the last 5 years than in the previous 50.
So the data exists.
Oh, it absolutely exists.
But accessing it feels like trying to drink from a fire hose in the dark.
That is a perfect way to put it.
Because if you were that clinic director trying to draft a care protocol or a national policymaker trying to allocate a budget, you just get blasted with isolated PDFs or, fragmented institutional websites. There's zero structure.
None.
And without structure, all that data is essentially useless at the actual point of care.
And that structural void is exactly what the Health and Migration Knowledge Hub was built to fill. It basically acts as the plumbing for that fire hose.
I love that.
Right? It takes this massive chaotic flow of global intelligence. So epidemiology, clinical risks, health system preparedness, and synthesizes it into an actionable architecture.
Well, let's break down the mechanics of that architecture because the sheer scope is immense.
Yeah.
I mean, updated as of April 2026, the hub is organized into 14 thematic sections.
14, yeah.
And it contains over 130 curated, peer-reviewed resources. It pulls together the absolute heaviest hitters in global health. You've got UN agencies like the WHO, UNHCR, IOM, UNICEF.
UNFPA.
Right, UNFPA.
Yeah.
Plus, it integrates labor and development data from the ILO and INDESA alongside displacement tracking from IDMC.
It's massive.
And then on top of all that, it layers in frontline medical protocols from the IFRC, IRC, and MSF, not to mention cutting-edge research from Lancet Migration and dozens of academic institutions. And crucially, it's entirely open access under a CC BY 4.0 license.
Which removes the first massive hurdle, right? Paywalls. By centralizing these resources under an open license, the hub guarantees that a rural physician has the exact same access to best practices as a researcher at some well-funded Western university.
But wait, here is a detail that genuinely stopped me in my tracks when we were preparing for this deep dive. This entire platform, this massive coordination of resources from the highest levels of the UN down to local operational protocols, it was produced with zero external funding.
Yeah, zero.
It is a fully volunteer initiative driven by the Georgian Medical Journal and the Public Health Institute of Georgia, or PHIG. And my immediate pushback was, how? How does a volunteer initiative avoid a massive drop in academic rigor? Because vetting over 130 resources across that many global institutions, it seems impossible without a multi-million-dollar grant.
It's a totally natural skepticism, but the rigor of the hub doesn't come from GMJ and PHIG generating new primary research from scratch. Their innovation is meticulous curation.
Right, they're the curators.
Exactly. They act as the architects. They select already validated high-impact evidence and arrange it so it can actually be utilized. It demonstrates a deeply mission-driven philosophy, which is that the knowledge to save lives already exists. It was just siloed. So they built the bridge themselves.
And every bridge needs a foundation. When you look at how the hub is organized, Section 1 is entirely dedicated to the World Health Organization's Health and Migration Program. This clearly functions as the normative anchor for the rest of the platform.
You simply cannot navigate global migration health without understanding the WHO's framework. I mean, the primary text here is the WHO Global Action Plan on the Health of Refugees and Migrants 2019 to 2030, which was recently extended by WHA 76.14.
Alongside their 2026 first Global Baseline Report.
Yes. And this establishes the global consensus on what health systems actually must achieve.
But the piece that translates that high-level consensus into actual human behavior is the WHO Global Competency Standards. The hub features this really prominently. It's a framework of 9 specific standards across 5 domains.
And the traction on that is incredible.
It is. It's been implemented in 113 countries, awarding over 600 certificates with more than 550 health workers trained in person across 13 countries. But, and here's my question, how do 9 standards work universally? You can't prescribe the exact same medical protocol in a high-tech hospital in Geneva as you do in a temporary transit camp.
Well, the brilliance of the competency standards is that they don't dictate clinical protocols. They dictate behavioral and structural approaches.
Okay, so what does that look like?
So the 5 domains focus on concepts like people-centeredness, communication, and evidence-informed practice. So the standard isn't prescribe this specific medication. The standard is how do you take a medical history through a trauma-informed, cross-cultural lens regardless of the resources you have.
Oh, wow. That distinction changes everything.
It really does. And it's moving rapidly from being just a UN recommendation into actual law. There is a massive milestone from February 2026 that's highlighted in the hub. Estonia, specifically the University of Tartu, became the first country globally to embed these WHO competency standards directly into its national medical education.
That is huge.
Consider the impact of that, right? A 22-year-old medical student in Estonia is no longer just memorizing anatomy. They're being fundamentally tested on how to recognize the unique vulnerabilities of a displaced person. Migration health is no longer an elective they might take in their final year. It is part of their baseline competence as a physician.
And the people curating the hub are actually driving this training on the ground, too.
Yeah.
I mean, Professor Georgi Kakadze, the founder and chair of PHIG, he actually served as the training facilitator at the WHO and IOM Health Mediator training in Riga, Latvia, back in September 2024.
Right, under the EU4 health program.
Exactly.
And that operational footprint is just crucial, because when the hub's architects are the very same people standing in a room in Riga actively training health mediators, the platform benefits from real operational authenticity. They curate the hub based on what a health worker actually needs when standing in front of a frightened patient.
Which brings us perfectly to the actual clinical tools those workers need. The evidence architecture of the hub surveys several critical domains. Let's look at 3 of them, starting with mental health. The hub curates the WHO DEHM Series Report 5 from 2023, the Joint MHGAP Humanitarian Intervention Guide, and the Refugee Health Screener 15, or the RHS 15.
The RHS 15 is a vital inclusion there.
Why is that one so important?
Because identifying psychological distress in a newly resettled population is incredibly difficult. Expressions of trauma vary vastly across cultures. So the RHS 15 is this validated instrument that allows clinicians to screen for things like PTSD and depression without relying solely on Western psychiatric constructs.
That makes total sense. Then you have Domain 2, which is climate and displacement. The hub features the WHO 2024 Evidence Brief and the 2025 Systematic Review. And these specifically link climate-related displacement to health system resilience, detailing how systems basically have to adapt to spikes in heat stress and waterborne diseases.
Yeah.
And finally, Domain 3 is child and reproductive health, highlighting UNICEF's Uprooted Report and the UNFPA's guidance on sexual and reproductive health in humanitarian settings.
Right.
But looking at these categories, something feels a bit off to me. You have mental health screening, climate resilience, and emergency obstetrics. In a standard hospital, those are three entirely different buildings. By throwing them all into one database, aren't we just recreated the clutter we are trying to avoid?
Well, see, that's the traditional static way of viewing medicine, but the experience of forced displacement fundamentally shatters those clinical silos. The hub deliberately integrates these domains because a displaced person does not experience trauma in neatly categorized departments.
Okay, walk me through how that actually looks for a patient.
Sure. Take the pregnant patient you mentioned at the beginning of our deep dive. A severe climate shock, say, a drought destroys her family's agricultural livelihood, forcing them to migrate.
Right.
That systemic climate shock directly triggers severe anxiety and depression. Then, that untreated mental trauma, which is compounded by the physical exhaustion of walking for weeks and relying on contaminated water sources, directly threatens her reproductive health and the viability of her pregnancy.
Oh, I see. So the clinician cannot treat the obstetrics emergency without treating the waterborne illness, which they can't fully understand without acknowledging the climate shock that caused the migration in the first place.
Precisely.
Hmm.
And if a policymaker is designing a maternal health program for refugees, they cannot succeed unless they understand the climate and mental health stressors impacting that exact same population. The hub's integrated architecture basically forces the user to see the holistic picture of human vulnerability.
But seeing the holistic picture clinically is useless if you hit a structural wall legally. I mean, a doctor might know exactly how to treat that patient, but what if the local government explicitly bars undocumented migrants from accessing the public hospital?
And that is exactly where the medical community has traditionally felt powerless. And it's why Section 14 of the Hub policy frameworks and normative architecture is perhaps its most potent tool. It shifts the focus from clinical symptoms to legal rights.
Okay, so let's unpack that section. The Hub curates 6 foundational policy frameworks here. We have the WHO Global Action Plan 2019 to 2030, the Global Compact for Safe, Orderly, and Regular Migration from 2018.
And its sister document, the Global Compact on Refugees.
Right. Then there is the New York Declaration for Refugees and Migrants from 2016, the Sustainable Development Goals, specifically SDG 3 on universal health coverage and SDG 10 on reduced inequalities. And finally, the Alma-Ata Declaration from 1978 and the Astana Declaration from 2018 on primary health care.
The foundational text.
Yes. And the Hub is explicit that these 6 instruments are the normative foundation for all research, clinical practice, and advocacy. But let's be honest, these sound like highly abstract pieces of UN jargon. If I am that clinic director trying to get funding for a translator, how does a document signed in Alma-Ata in 1978 help me today?
Because that 1978 document is not just a piece of history, it is an active legal lever. The Alma-Ata Declaration established health as a fundamental human right and primary care as the mechanism to deliver it. So imagine that clinic director goes to their regional health ministry and asks for resources to treat a sudden influx of refugees. The ministry says, we do not have the mandate to spend citizen tax dollars on non-citizens.
A very common political roadblock.
Extremely common. But armed with the Hub, that clinic director can point to the 2018 Global Compact on Refugees that their own government legally signed and pair it with the Alma-Ata Declaration and say, actually, under the international frameworks you adopted, you are legally obligated to provide primary health care without discrimination. Right. These frameworks dictate government accountability and international funding flows. The Hub takes these massive, intimidating legal texts and structures them into a single reference table so an advocate knows exactly which lever to pull to change national policy.
That is incredibly empowering. It arms the clinician with the law.
Yeah.
But even with the evidence and the legal levers, none of this works if the workforce doesn't know how to use them. How does someone actually learn to synthesize all this?
And the Hub answers that in its training, education, and capacity building sections, because generating evidence is only half the battle, you know? The other half is upskilling the people on the ground.
And the professional development resources curated here are wild. You have the WHO Academy free online course, which is 6 modules, takes about 6 hours, and yields an actual certificate of achievement. And it's already reaching learners in 113 countries.
It's fantastic.
Then there are the IOM Global Migration Health Training Programs and specific courses from CAMH in Canada, focusing purely on immigrant and refugee mental health. And for those looking for advanced academic study, the Hub curates over 10 postgraduate master's degrees from institutions like Oxford, the London School of Hygiene and Tropical Medicine, and Sciences Po.
Yeah, but what stands out to me most in that section is the ECDC e-learning series.
Oh.
Yeah, the European Center for Disease Prevention and Control tailored these modules specifically for health professionals, social workers, and trainers. And critically, they made them available in 24 different languages.
Why is the language aspect so vital there?
Well, imagine a Romanian social worker trying to assist a Syrian refugee. The cultural and linguistic gaps are immense. If the best training materials on cross-cultural trauma care are only available in technical English behind a paywall in London, that social worker is left guessing. By curating the ECDC modules, the Hub ensures that social worker can log on, access world-class training in their native Romanian for free, and immediately apply that knowledge to the patient in front of them.
It is essentially a globally crowdsourced university. You can jump from a free 6-hour module in your native language to applying for a master's degree at Oxford, all from a single web page. It completely shatters the barrier of access.
And that is the ultimate achievement of GMJ and PHIG here. They recognize that the inequitable distribution of knowledge actively harms patients. So by democratizing access to this data, they are democratizing the ability to heal.
We have covered so much ground today. We've looked at the massive scale of the crisis, the ingenious volunteer curation of the Hub, the WHO behavioral standards changing medical schools in Estonia, the integration of climate and mental health, and the legal levers like Alma Ata. It is a really comprehensive roadmap.
It is, but I want to leave you with a provocative thought that underscores why we must use this roadmap urgently. There is a 2026 Lancet Regional Health Meta-Analysis by Ben Brick and colleagues featured in the Hub's academic section. They analyzed 89 studies with over 14,000 participants.
Okay, what do they find?
The data reveals that migration status alone more than doubles the odds of a person contracting a communicable disease, an odds ratio of 2.16. For forced migration, it is even higher at 2.87. But the most alarming part of the study is what it calls the implementation gap.
The implementation gap.
Yeah, it shows that our downstream clinical interventions vastly outnumber our upstream systemic policy changes.
Meaning, the global health community is spending nearly all of its energy treating the illnesses after they happen at the clinic door, rather than fixing the broken structural systems that make displaced people sick in the first place.
We are fighting the symptoms, not the disease. The root causes of migrant health disparities are structural, legal, and environmental. Yet our responses remain overwhelmingly confined to the exam room.
Which brings us back to that triage nurse we talked about, and to you. This platform, the Health and Migration Knowledge Hub, has finally given us the structure to see the whole picture. You have the clinical tools to treat the symptoms and the legal and policy frameworks to attack the root causes, all in one centralized place. The question is, what are we going to do with it? Are we going to keep treating the downstream symptoms of displacement, or are we finally ready to use this knowledge to cure the structural inequalities causing them? I highly encourage you to go explore the Hub for yourself at the Georgian Medical Journal website. Thank you so much for joining us on this deep dive.